Good afternoon, good morning, some of you. Welcome to the Bipartisan Policy Center's virtual discussion of the COVID-19 and rural health. I'm Bill Hoagland. I'm Senior Vice President here at the Bipartisan Policy Center, and I have the pleasure of working with our health team led by Marilyn Serapini, Catherine Hayes, and Dr. Anand Parekh. We at the center, probably like a lot of you, have been adjusting to this new mode of operation through video, and we hope it goes well today, as I know I will. Today's Zoom conference is focused on an issue that's very close to my heart. I grew up on a farm in the Midwest, and the family farm is still operational today with my brothers. In a family Zoom conference, something like this, with my family earlier this week, all fortunately healthy and safe at this time. Nonetheless, they were very aware of cases of the virus in that small rural community, and understandably were very concerned, particularly about how they would receive medical care if they needed it. The virus, we know, knows no boundaries, whether it's urban, suburban, farm, rural, ranch, and yet we know that to date, big cities and major urban areas have seen the greatest number of coronavirus cases and deaths. But there's a recent analysis from the Kaiser Foundation finds that the growth rate is higher in rural areas. For the 2 weeks ending April 27th, rural communities saw a 125% increase in virus cases and 113% increase in deaths. Both rates of increase almost double what was in the metropolitan counties. Today, one of our founders of the Bipartisan Policy Center, Senator Tom Daschle, he's going to discuss the challenges this virus is creating in rural and frontier areas with leaders of some of our great health systems that are operational in these areas of our country. As we know, the rural hospitals were facing significant challenges even prior to the novel coronavirus, and now even more so. Last month, the Bipartisan Policy Center issued an important report entitled Confronting Rural America's Healthcare Crisis. That report's policy recommendations were spearheaded by a high-level task force chaired by Senator Tom Daschle and Senator Olympia Snowe, former governor of Mississippi, Ronnie Musgrove, and former Wisconsin governor and Secretary of Health and Human Services, Tommy Thompson. Senator Daschle will shortly touch on some of those recommendations. So for those of you who are joining us on this Zoom page, you can find the full task force recommendations in the chat option. Others joining us through YouTube can go to our website, thebipartisanpolicy.org, and find them there. Also, one logistic issue before we get into it, should you have any questions of the senator or the panelists that he will introduce, you can ask those questions clicking on the Q&A icon at the bottom of your screen. Before turning this over to Senator Daschle, let me introduce Mitch Krebs. He's the program director of the Helmsley Rural Healthcare Program. We are thankful to the Helmsley Charitable Trust, Mitch, and all that you've done to help us support this work here at BPC. So, Mitch, I'm turning to you, and you'll introduce Senator Daschle.
All right, thank you very much, Bill. Eloquently put, as always. And we at Helmsley Charitable Trust, we share your passion for rural health care. I want to thank everyone on the call for focusing your attention on rural health care. Our trustee, Walter Panzier, sends his greetings as well. As Bill mentioned, Helmsley is a proud partner with BPC. Our funding is support of the educational efforts of the Rural Healthcare Task Force that he just talked a little bit about. To tell you a little bit about the Rural Healthcare Program within Helmsley's Charitable Trust, in our first 10 years, we've dispersed more than $420 million in grants to the upper Midwestern states to make sure rural residents have access to the best healthcare, just like those available to folks in urban areas. So simply put, our philosophy is that the zip code where you live shouldn't determine the level of or quality of healthcare that you receive, or even whether a person lives or dies. About $100 million of that funding has gone to support the development and use of telemedicine. And it's hard to find a silver lining with COVID-19, but if there is one, it's that the response has shed the light on telemedicine's efficacy, which has led to more adoption and use of the technology that's been proven in rural areas for years. And that necessity has led to a lot of the barriers that have kept telemedicine from spreading to come down. I know there are a lot of efforts being made right now to make sure that those changes are made permanent. Well, besides the obvious loss of lives and suffering from the virus, another catastrophic effect is the financial damage to the healthcare system. As Bill just mentioned, hospitals have had razor-thin operating margins for a long time now in rural areas and even prior to COVID. And many are losing more than $1 million a day, as has been reported by several CEOs as this crisis goes on. So obviously we need to do all that we can to ensure that rural healthcare stays viable and effective, because too many hospitals were closing prior to COVID-19, and that situation is only going to get worse without thoughtful and effective action now. So thank you again to the panelists that are joining us today, and all of you that are joining us online. I hope you all are healthy and safe at home. And also to BPC and today's moderator, my friend Senator Tom Daschle, who hails from the great state of South Dakota, and it is my distinct honor to introduce Senator Daschle.
Thank you very much, Mitch, for that introduction and for your great support over these many years. We are very grateful to you and Hemsley for all that you've done and the leadership you provided. Early on in this pandemic, the focus was on the rapidly growing numbers of confirmed cases, hospitalizations, and deaths in big cities like New York and New Orleans. What we did not hear much about was the impact on rural communities until very recently. Just a couple of weeks ago, South Dakota, which Mitch noted I represented for many years in Congress, was the nation's #1 hotspot for the coronavirus because of an outbreak at Smithfield Foods. But the impact on rural health goes way beyond the number of coronavirus cases showing up in emergency departments. For rural hospitals in particular, it is also about their ability to survive financially, to be there for their communities, both now and also after coronavirus is a thing of the past. Many rural hospitals were struggling before the pandemic. More than 100 rural hospitals have closed since 2010. Today, nearly 600 are at the risk of folding. So let's be clear, when they close, people in rural areas have no choice but to drive long distances to get the health care they need or not get care at all. Add coronavirus to the mix, and the financial situation has become dire for some rural hospitals. Many are laying off or furloughing significant portions of their staff. From the beginning of this pandemic, rural health systems did exactly what they were supposed to be doing and what all hospitals were doing. They put a quick stop to elective procedures, those procedures that are not time sensitive. While some hospitals can absorb the loss of revenue, many rural hospitals simply cannot. Over the past year, I've co-chaired a task force at the Bipartisan Policy Center that Bill mentioned. We released our recommendations on April 21st. They're designed to improve rural healthcare. Even before we knew about the pandemic, the task force recognized the clear need to provide immediate financial relief to rural hospitals and clinics, temporarily for 3 years, to allow for hospitals to consider transforming to models that focus less on inpatient care. We also recommended policy changes to make it easier for rural providers to move to value-based care, to encourage clinicians to come to rural areas and to stay there, to stop the wave of obstetric unit closures, and to improve access to care by breaking down barriers to telehealth services. Recently, Congress and the Trump administration waived many Medicare restrictions for telehealth in response to the virus. They've eased restrictions around the site of service. They've also allowed telehealth for patients who are not already established with a clinician. There are also new flexibilities allowing payments for phone calls, and other visits that are not visual. Congress has temporarily allowed a patient's home to be an originating telehealth site. These changes are consistent with our task force recommendations and should be made permanent. While the virus has been devastating, it's provided a valuable learning experience to see how well some of these changes are going to work and how we can continue to use them after the pandemic. Today, we're going to hear from 4 rural health systems: Marshfield, Geisinger, Dartmouth, Hitchcock, and Knoxville. They're going to give us a firsthand look at the problems they're experiencing as a result of the coronavirus. I'd like to introduce our panelists for today. Dr. Joanne Conroy is the CEO of Dartmouth Hitchcock in New Hampshire. Dr. Conroy has a wealth of experience in transforming the system's financial outlook and employee satisfaction while working to increase access to care for her communities. Currently, the Dartmouth Hitchcock Health Systems serve a population of 1.9 million people across northern New England and serving as one of 9 hubs in the state's hub and spoke model for delivering care to victims of the opioid crisis. Kevin Kincaid is the CEO of Knoxville Hospital and Clinics in Knoxville, Iowa. Kevin has served as CEO since 2011 and has a stellar record in identifying strategies, initiatives, and administrative practices to support growth, service excellence, and employee community relations. Karen Murphy is the Executive Vice President and Chief Innovation Officer and Founding Director of Geisinger's Steele Institute for Health Innovations. Dr. Murphy holds a PhD in Business Administration and a degree in nursing. Before joining Geisinger, she served as Pennsylvania's Secretary of Health and has consistently worked to improve and transform healthcare delivery throughout her career in both the public and private sectors. Geisinger currently serves communities throughout Northeast, Central, and South Central Pennsylvania. Dr. Susan Turney is the CEO of Marshfield Clinic Health Systems in Wisconsin. Dr. Turney practiced internal medicine at Marshfield Clinic for 22 years and served as the chair of the Department of Internal Medicine and the medical director for patient financial services. She became CEO of the system in 2014. Marshfield Clinic is one of a few large independent nonprofit medical clinics in the United States. So welcome to each of our distinguished experts and leaders in rural health. And Karen and Kevin, let me start with you. We have a lot of questions, and I see there's already many that are coming in on the online. But as I noted in my opening remarks, even before the pandemic, rural hospitals were facing significant financial challenges. More than 100 rural hospitals have closed, as I noted, since 2010, and there may be 600 at risk of folding. I'd like, if I could, to ask both of you, and I'd invite others the other panelists to join us if they have other thoughts to add, but what are the main factors behind this extraordinarily ominous trend? Karen, let me start with you and we'll turn to Kevin.
Sure, thanks, Senator, and thanks for having me here today to talk about this important issue. The problems facing rural hospitals really have evolved over the last 20 to 25 years. And I think that sometimes we talk about the geography, but largely due to changes in healthcare delivery over the last 20 years. So acute care 25, 30 years ago could be fairly straightforward and could be performed relatively easy in most acute care settings. We've evolved over the last 2 decades to decrease nationally inpatient admissions. And at the same time, patients that have been admitted to the hospital really require very complex, specialized, sophisticated technology and a host of specialists to take care of patients on the acute care side. This has presented significant challenges for rural hospitals because they are challenged, as we noted in our report, they are challenged with recruiting specialists, recruiting physicians needed to provide that specialized care. And also they don't have the financial wherewithal because the last 20 years of declining inpatient admissions have largely contributed to low days cash on hand, poor physical plants that really are not amenable to what acute care looks like today.
Yeah, and thank you, Senator Daschle, for that question. Each state has a little bit of its own dynamics of what's created the financial situation that small community hospitals face. Iowa has 145 hospitals and 82 of them are critical access hospitals, so very rural healthcare model. Pre-COVID, the average operating margin in Iowa was negative 2.8%. So it was a bad situation to begin with. And frankly, it comes down to a lot of things. Like you could say Iowa's a little bit different as it relates to there's only one dominant commercial payer in the state. There are different dynamics like that, but certainly really what it comes down to me is it's a significant math problem. Is that if you believe, as I do, that the women in my service area deserve as good a mammography equipment as you can find in the urban areas. And so I might do 10 to 15 mammographies a day. You go to a metropolitan area, they maybe do up to 60. So, that equipment costs the same. And as a matter of fact, I may have paid a little bit more for it. So when I lived in San Diego, the game was there was lots of people. And so you could via, improving your quality, doing some marketing and outreach to other areas, you could increase your patient volumes through these service lines and help fund some of the things that you're trying to do with technology and improvements in services. But in the rural area, we have a lot of places that may have 100% of the market catchment. And they're, the only thing that you can do is if you have a stumble in quality, you could lose patients. There's really not any more to gain. So it really becomes a math problem as it relates to as we've had decreased reimbursements like everybody else, our costs have gone up like everybody else, but we don't have the volumes to be able to make that up. That's the fundamental issue as I see it that we had facing us economically.
So Susan, let me ask you, how much worse has the financial situation become since the pandemic began, and what are the causes behind how this situation has continued to erode? Susan, you're still on mute.
I'm off. There, it didn't click off. I apologize. Thank you. Thank you for the question. And clearly, this is something that's near and dear to my heart. We are a health system that has operated on very thin margins for years. And just to add on a little bit to the question that you asked, the first two people who spoke, is that why are we in this dire situation? Well, we are the largest employer in the northern 2/3 of the state of Wisconsin. There are only 1.2 million people that live there. However, the population is older, sicker, and poorer than in many other places of the country. We have an average household income of $8,000 less than the state average, which is pretty significant. We also know that many areas of the where we provide care in over 50 sites in that communities that we serve are did not have much recovery from 2008. And then an added dimension to all of this is that in some of the counties that were in the 41 county service area that we're in, we have less than 1.5 people working for every Medicare beneficiary. So you can see that we have a situation right from the get-go that creates some real challenges. So when we faced the pandemic 6-8 weeks ago, we realized that we had to do what everybody else was doing. We had to get ready for the worst case scenario that required intensive resource commitment. It also meant that we had to really think about doing business differently. There's also the situation where, like others, we did cease our elective procedures, and we also eliminated most of our ambulatory care. So in a few weeks, our revenue was down almost $60 million. That's a big hole, and it's a big challenge to dig out of as we're thinking about what the next iteration will look like for our as we reboot to bring services back to our patient care. But I think the things that I worry about a great deal are that we didn't see the surge like other places of the country, although we are seeing an increase now in our service area with a projected surge to be the end of May. So we'll have to wait and see. But we also know that people have delayed care. We know that there are people that are not getting the care that they need for their chronic illnesses. And investing in the resources both within our facilities through telehealth, which we'll talk about later, as well as working more closely with our community service agencies, including the public health services, requires a very intensive effort that we haven't seen in the recent past. So again, just unique challenges that we're all facing, but I think the depth and breadth of what we're facing, just because of where we're located, has been quite significant.
Joanne, we've talked a lot already about the unique circumstances that people face in rural communities, and hospital administrators and providers face in providing services in a rural setting. But could you just elaborate more on the differences that exist between rural and urban areas in responding especially to COVID? There are striking differences, and I'd be interested in your observations about how those differences really play out as you consider addressing the challenges we face in rural areas.
Thank you, Senator. So at Dartmouth-Hitchcock, we are fortunate. We're the most rural academic medical center in the country, but we have eyes on our own critical access hospitals and rural community hospitals. We also support 18 other small hospitals across New Hampshire and Vermont through an organization called NIA, which helps all of them perform at a higher level. So what happens when the COVID crisis strikes a rural hospital? It becomes a resource challenge for them. First of all, the first thing that we did as an academic medical center is stand up incident command. Most of our rural facilities do not have the expertise or infrastructure to stand up a team to plan for every imaginable assault on their facility by a surge of patients. The second thing is testing. We were able to stand up our own lab within 19 days. Many of these rural hospitals did not have access to adequate testing. The third aspect is contact tracing and working with community public health leaders to identify close contacts of infected individuals in the community. Well, the public health infrastructure in many of our rural areas is woefully under-resourced, and that is the key to actually identifying and controlling a breakout in your community. And I would say finally, personal protective equipment, which nobody in the US knew what PPE meant 8 weeks ago, but everybody understands what it means now. At one point, we were paying $6 for every single mask that used to cost 60 cents. Wow. So imagine, we spent $11 million for our health system over the last 8 weeks. Imagine what a rural hospital who's already financially constrained, the challenge that they're facing. And if they do get a COVID patient, it's 30 to 40 changes of PPE every single day to care for that patient. And they have to almost restrict access to the area where the patient's being cared for. These are institutions whose bench strength is 1 or 2 people. They don't have an army of staff to deploy to care for these very sick patients. So It's a very different challenge than you saw in the urban setting, but just as real.
Thank you. Excellent. I'd be curious, Susan and Kevin, if you could, and I hope this isn't too invasive a question, but to what extent have you had to lay off or furlough employees, and to what and what do you expect will be the long-term effects of those cutbacks if as you consider not only the balance of this year, but even beyond that?
So here at the Knoxville Hospital, I mean, I've always said that the COVID virus has devastated every hospital in the country, just in different ways. In our county where we sit, we have currently, as of today, 16 positive cases, a handful of hospitalizations, and no deaths. Yet we're being crushed by this virus. So it's impacted everyone. And in order for us to remain viable as an organization, we furloughed 40% of our staff out of 250 employees. These are the highest paid individuals in our community. So we have our highest paid employees that were left working took 10 to 15% pay cuts. There were benefit cuts. Long term, you know, the PPP through the Small Business Administration really helped us get that back on track, and so that we could maintain the employment of those employees. So that's been incredibly helpful. But long-term impact, we were a growing organization. We were on the verge of just a few weeks away from breaking ground on a brand new surgery center, new pharmacy, and a brand new visiting specialty clinic. And a lot of other growth in our community as well. That is all suspended until we can figure out what the economic damage has been long-term, and what does our revenue streams look like moving forward. Because you know, it's interesting, right before COVID-19, from the Chartis Center, we were recognized as a top 100 performing hospital in the country. And a lot of those are financial metrics. And yet we've been devastated financially within weeks. And so that's a story that I think needs to be told, and that people understand just how we were impacted by doing the right thing. The right thing was quit doing elective procedures. That's 80% of my revenue, outpatient testing, elective procedures. We went down to just a snail's pace in revenue, and it has devastated us quickly.
Thank you. Susan.
You know, like others, we've had a very similar experience when we had to make the decision, which was the right decision, to stop doing elective procedures, and much of the ambulatory care. We knew that we could not keep our entire workforce on site.
Susan, you're breaking up a little bit. I'm not.
To continue work that just wasn't there. So we for work for that. Yes. And this was important because we needed to protect our patients, we needed to protect our providers, we needed to protect our staff during this very challenging time. And you know, what we're going to be doing going forward will likely look different. We know that we're not going to turn or flip a switch and everything's going to come back in and we're going to look exactly tomorrow like we did 2 or 3 months ago. We know that it's going to be cranking up the dial and bringing back patients that need care in a very purposeful, very thoughtful way, again, to protect them and to protect our staff. So it's going to be a long road to recovery. It's going to be months or even years for us to get back to where we had had been. And that is doesn't mean it's going to look like it did. It means that we're going to continue to do the right things and change the care model in a way to best accommodate our patient needs.
Karen, let me ask you, the federal government has directed significant funds to hospitals across the country. How much has Geisinger seen of that assistance so far, and how long will it help, and would you consider it adequate?
So that's a great question, Senator. We've estimated Geisinger is losing approximately $100 million a month enterprise-wide. To date, we've received somewhere in the neighborhood of $45 million in federal funding. We also have a state loan program that we're very grateful for, but it surely is not adequate in terms of completely filling the gaps that we have. And I think, as the other presenters had mentioned, it's very clear to us that coming back is not coming back to where we were before, and that we will be required to develop a new business model that matches the revenue challenge, our expenses with the revenue challenges. But it's pretty clear to us that it's a long trajectory of recovery, or it will just become, it won't be recovery to pre-COVID, it'll be how do we operate in this new normal.
Joanne, let me follow up with, if I could, and I'd open this up to any of our presenters, but if you could talk to all 535 members of Congress about our circumstances in rural health and public policy going forward. They're obviously currently contemplating the fifth phase of additional assistance. What, from a policy perspective, would be the most helpful to you and to rural hospitals in general?
So I would say there are four things I'd want them to consider. The first is to look at the Medicare Accelerated Payment Program. I think that they need to look at both the time with which those monies are repaid, the interest rate that is associated with that, and or consider whether or not they should make some of those straightforward grants to rural hospitals. I think almost every rural hospital is going to have a hard time paying that money back. I say the second thing is they did great work to really liberate telehealth, and they need to continue to do that. And probably to kind of support it with some broadband infrastructure, which creates significant challenges in all of our areas. I would say the third thing that I'd want them to consider would be a lot of the regulatory relief that they have allowed us to, had they waived, a lot of that should probably continue, because it's allowed us to be much more nimble in using our facilities at a time where none of us really knew what the future was going to look like. And I would say finally, and most importantly, we believe we're going to face some significant increases in unemployment. Much of that is associated with people that are losing their employer-sponsored coverage. And if there's a pathway to keep those individuals and their families covered from a health insurance perspective, that will be critically important. We expect we will see many people that are uninsured in the future until we recover financially as a nation. And that is going to impact critical access in rural hospitals very quickly.
Do any of the presenters want to add to Joanne's excellent list?
Senator Daschle, one that I would add, I do want to echo how important I think the accelerated payments need to be looked at, and from a forgiveness perspective, because legislatively, I can't think of anything more simple to do. The money's been allocated. There's been a mechanism to scale it. It was incredibly helpful to keep our heads above water, but we don't know how long this is going to go on. And this is something that would be incredibly beneficial, and I think very easy to be done legislatively. Forgive the accelerated payments. We're pleading with that every day. Another thing that we've also been trying to work with the Senate Finance Committee on is actually working on a new hospital designation for rural hospitals and actually call them rural emergency hospitals. And in Iowa, we had last year 53 hospitals with an average daily census of 3 or less. And in order, there's a lot of hidden costs and a lot of just upfront costs in maintaining acute care services. And hospitals and local boards and communities could choose to give that up, in exchange be paid at a higher cost level for their emergency services and other services in their outpatient setting to scale the hospital to an appropriate size. So the rural emergency hospital program that's been kicked around a little bit, we think this is a great opportunity to restructure rural care in a more organized fashion that makes sense for how care is delivered today.
What I would add is, I think first I'd say thank you, because I think they have a very difficult job deciding how the money is being dispersed. But I also think that what you're hearing here is that the 20% of Americans that live and receive care in rural areas have unique challenges. And it's not just about the number of COVID patients, it's about everything else that surrounded. And I see the internet connection is unstable again. This is one of the challenges we have in rural America, broadband access. Yeah, so I think, again, recognizing the unique challenges that we have. If that's not the case, I think all the risk that we've discussed around failure of healthcare in rural communities will be magnified. And again, just to emphasize that we're not just the provider, we're oftentimes the largest employer, and we support all those other small businesses in the areas where we reside. So again, I think it's critical that we recognize there are unique differences and not to forget us in these discussions.
Let me segue, if I can, to somewhat of a sensitive issue, and I'm going to direct this initially to Joanne and to Karen. The pandemic has increased the demand for mental and behavioral health services, and that increase is expected to continue in rural areas in particular as they cope with depression and anxiety and substance abuse. Could you just share with us how you think you are situated for behavioral health professionals, and how prepared are we generally to deal with the increased need in mental and behavioral health today?
So, Senator, I think right now we don't completely appreciate how much stress our behavioral health patients are currently under. They're a little bit invisible because of the stay-at-home orders. We have not seen the normal volume of behavioral health patients in our emergency rooms, children or women that are in abusive relationships. They haven't actually presented publicly because of the stay-at-home orders. So number one, all of us think it's going on, it's at its endemic rate, but it's probably a lot worse. We are fortunate in that as an academic medical center with a large teaching program, we have a lot of psychiatrists here. But getting psychiatrists and psychologists and social workers out into rural communities is actually very difficult. It's hard to recruit them there. And frankly, it is a challenge to have them actually get in a car and drive 2 hours to go to one of our offsite areas. I would say we've got to reinvent our behavioral health model, which may not mean sitting on somebody's couch for 50 minutes in their office. It has to use a lot of the telehealth opportunities, and I know we're going to talk about that in a little bit detail later, but we have to create a new way of meeting patients where they are. And that may mean having a video chat with an adolescent in their bedroom over FaceTime or Doximity or one of our more secure messaging vehicles. But we've got to meet them where they are. because our current model cannot actually be scaled in order to meet the demand. But I would remind people, I think we have an emerging wave of people with behavioral health needs that once we lift the restrictions for people to travel, we're going to start seeing it very quickly.
Karen?
So we also have a shortage, despite the size of Geisinger, we also have a shortage of behavioral health practitioners. I would say that there has been some silver linings during this pandemic that we have recognized. One of those, and we're going to talk about telehealth later, but one of the leveraging virtual visits, what our psychiatry department, our behavioral health department has seen is a soar in productivity of practitioners and a real decline in no-show visits that we ordinarily experience. So we're hoping that that's a bright light to be able to expand that capability for behavioral health because we all are so short. I think there's other there's other innovations in this area, such as digital applications, group therapy sessions via apps. And I think to Joanne's point, we are going to have to rethink the behavioral health care model because we just throughout the country do not have the capability of delivering the care that's needed and equally as needed in the behavioral health space. And I would add the other part that we're very concerned about also post-COVID is the impact that COVID has had on our workforce. And we have developed a program called RISE, which is Resilience in Stressful Events, for peer-to-peer support throughout the COVID. But we believe that, and what we're calling is post-crisis, is that we're going to see significant challenges among healthcare workforce in behavioral health as well.
We have a lot of questions coming in, and I want to make sure we leave time to turn to them, but we've referenced telehealth throughout our conversation already today. But let me just, I mentioned in my opening comments that I co-chaired a BPC task force last month, and we released a set of recommendations for a number of changes that would make it easier for people in rural America to use telehealth. Karen was one of our terrific participants in that task force, and Congress has made a number of changes to allow more flexibility in telehealth services, and I think many of those changes now have been pretty consistent with the proposals that we made. So I'd like to end this part of our conversation before we turn it to audience questions by asking each of our panelists if they could just briefly talk about what the world of telehealth in rural America is going to look like, and what do you think of the changes that have been made, and what, if any, specific recommendations you'd have for further changes going forward. Let's try to be a little brief, but I think it would be very helpful for each of you to give us your insights on the critical role telehealth will play in the future. And let me start with Kevin, and then we'll go to Joanne, and then Susan, and then Karen.
Well, the recent changes that's come about of helping us get paid for using telehealth have been wonderful, and we're incredibly grateful for that. But what in our setting, we've been involved in telehealth virtual visits for a couple of years, but frankly, in our service area, people largely didn't want it. They wanted to see face-to-face their provider, and this situation we found ourselves in here has led to the public seeing that, hey, this works and it's pretty slick. And our providers that were reluctant about it because their patients didn't really want it anyway, they also seen, hey, this is pretty slick. So frankly, I think that telehealth, as it relates to technology and community hospitals, we're getting with the times, and I love it.
Terrific.
So I'd say at Dartmouth Hitchcock, we've got a great example of provider to provider telehealth. over 20 institutions actually use our tele-ED. But what was most interesting is we actually took care of a COVID patient who was quite ill in southwestern Vermont, connecting our ICUs and our providers. The patient was almost too sick to transport. And we helped the nurses and the physicians on site actually care for that patient. And he was discharged to home from that hospital 7 or 8 days later.
Wow.
I think this is the future of rural healthcare, is actually using provider to provider support so they can actually keep patients in the facility and care for them appropriately. And we demonstrated the first week of the crisis that that could be done effectively.
Susan?
You know, we've been doing telehealth for a long time, but again, I already mentioned some of the challenges. A lot of our patients don't have broadband access, probably 20 to 25% of them. And in fact, about 60% of our virtual visits are through telephone. So we were grateful that there were some changes made so that we could get reimbursed for the care, because those patients really needed that touch point. But we have a long way to go to be able to deliver the service I think that everyone would expect if they're going to be using telehealth as a means of care delivery. But it isn't just that ambulatory care. It really needs to extend into home health, into hospital at home, to other home nursing care, and also working with our public health institutions and really connecting the dots across the whole ecosystem to really leverage the technology to really do what's best for our patient care. Yet we do know for the patients that have been willing to be seen through these modalities or be listened to through these modalities, there's a very, very, very high satisfaction rate, 4.8, 4.9 out of 5. So again, it's here. One of my biggest concerns is that many of the insurance companies have their policies expiring coming up in June. And if that's the case, it could set us back a decade. So we need to stay up front and center on the design of the care models and looking for ways to get reimbursed for those services to, again, meet the patient where they're at and really give the care to the patients that they deserve.
Karen?
I think building on that, if we were talking to Congress today, we should emphasize not only about telehealth, but the necessary move to value-based payment. We have proven through this pandemic that the fee-for-service model is abysmal. It's broken. It has caused really all of the problem. We all did the right thing. We moved to virtual health. We shut down our elective surgery, and it led to economic disaster. I think working and accelerating the move to value-based payment allow us to do, whether it be care in the home, whether it be virtual care, develop payment models that incentivizes providers to do the right thing and to develop sustainable business models.
Well, thank you for those insights. Very, very helpful. We're going to turn now to questions from our large viewing audience. And I'll take the first question and I will just leave it to one of you to respond, and please feel free for more than one if there are others of you who would like to answer the question. The question is, what will be the steps towards resuming elective procedures? And when do you believe this will happen?
So I'll start that. We are all trying to be aligned with our state guidelines, and every single state is talking about what steps we take to do time sensitive and then ultimately elective procedures. I would say, regardless of our willingness and ability to do these, the most important thing we have to do is convince patients that when they come to our facilities, 3 things occur: that they're not going to get COVID-19 from another patient, and we are probably safer than many other public places people go right now. Number 2, that all of our institutions are clean. Every surface is cleaned by an army of our housekeeping staff every single day. And finally, that we have enough PPE to protect both them and the people that care for them. And we've got to say that again and again and again to actually earn back the public trust that our facilities are safe places to be.
Another viewer asks, rural hospitals are closely tied to clinics. How are the clinics faring during the pandemic?
Um, our, our clinics, we have outlying clinics in our smallest communities in our service areas, and two of those have been temporarily suspended, both for a clinical reason, for us to figure out how to safely get people screened and in. We didn't have the resources for that, to have multiple entrances. So we've brought that all back to the main medical center. So in these rural clinics that we have, most of the services that were being provided were the things that we were currently delaying for obvious reasons. So we're anxiously awaiting for the ability to get those reopened, but it has severely impacted the smallest of our communities around us.
A question about hospital revenue. Would allowing rural hospitals to temporarily switch to a cost-based payment method instead of PPS during the public health emergency help control costs? Have critical access hospitals or sole community hospitals fared any better than those hospitals that get paid through the prospective payment system during this time?
Well, being a CEO of a critical access hospital, I guess I'll jump on that one, is that when you have revenues declining at these levels, and our cost per unit, so all of the critical access hospitals are going to be doing interim cost reports, because certainly our costs per whatever we do has gone up, but it doesn't in any way, shape, or form make up for the losses that we've seen, significant losses in revenue. And anybody that's not familiar with cost-based kind of reimbursement models, it comes down to allowable costs. And allowable costs are a much different thing than just the overall costs of being able to run the medical center. So I think that there are situations where that could be beneficial, but frankly, we believe that there's better overall models than that. But currently, we are being devastated just like PPS.
I have a question on telehealth. Government agencies and hospitals throughout the country are currently using remote monitoring technology to enable patients to be monitored safely at home. As we work towards not only reopening the economy, but also at putting measures in place to prevent the problem we saw with COVID-19 and providing access to patients in rural areas, what role should remote physiological monitoring have, or psychologic monitoring have?
Well, I'll take a stab at that one. I think that remote monitoring is a wonderful way to manage people with chronic diseases in their home. It gets back to the challenge of rural healthcare, though, that the broadband access, and even in some of our households, their financial ability to have the appropriate devices to actually perform remote monitoring and to communicate with their providers is really limited. We have a program called Moms in Recovery that we work with moms that are struggling with opiate use disorder. And we pick them out during their pregnancy and post-delivery. We discovered that those moms are really willing to actually connect during this crisis with devices, but they actually either don't have a device or can't actually afford the ongoing monthly plan payments to actually maintain that connectivity. So things that people take for granted in cities that, Wi-Fi hotspots and great broadband access, that's a huge challenge, both for telehealth, but certainly for remote monitoring. Karen, I don't know if you want to say anything else about that.
Yes, thank you. So we are working on strategies for remote monitoring and changing the way we look at chronic disease management. And again, I think what we should all be talking about now and looking at the last 2 months and how we go forward is truly transformation. So in order to achieve that transformation in a rural setting, we are going to need to deliver healthcare in a digital way. And I think that when we're looking at transforming the payment system, we're looking at extending broadband. Also, when you're on value-based payment, if we had the ability to eliminate the unnecessary things that we do that generate revenue, perhaps we would be able to take some of our revenue and give it to the people that need it, like your moms that need. We could subsidize if we were paid on outcomes, as opposed to paying by the number of services that we deliver. And I think our theme coming out of COVID should be transformation, transformation, transformation.
So, Susan, go ahead.
I think, we all know that remote monitoring for chronic diseases is very important and extremely valuable. And we know that patients do have better outcome. And as we're shifting, to your point, Karen, the model of care and not getting paid on a piecemeal basis for interventions that may not make a difference, but really paying for the outcome of less emergency room visits, less hospital admissions or readmissions for patients with chronic diseases like congestive heart failure. It just makes so much sense because there's a huge investment to beginning these programs and then maintaining the programs. Even if you partner with someone who does great work in this area, there's a lot of infrastructure that has to be built and maintained to make it successful. So I think shifting the payment to where it has the biggest impact is likely the most important thing that we could do to really evolve care that extends beyond the four walls of the clinics or the hospitals that we all work in today.
Joanne, there's a question that's come in for you directly. Has the New England Alliance for Health been successful in providing and sharing resources with rural hospitals to help them prepare for COVID? And to what extent does the organization expertise provide an opportunity for serving as a model for other rural areas?
It's a great question. So the New England Alliance for Health has over 20 small rural hospitals that participate in the organization. We meet every month and have calls again every month as well. So twice a month people are connecting. There are a couple things that we do for the members. Number one, we have a shared supply chain. So they actually get to take advantage of the lower prices for not only all their supplies, but their pharmaceuticals. And that's really important. Number two, we set up a networking opportunity so they all share what's working within their own organizations. The third thing that we've done is we actually set up this Project Echo around COVID. So basically, not only all those hospitals, but other hospitals actually participated in understanding what we were learning from our incident command and how we were setting up our policies and procedures and patient flow. So they didn't have to reinvent the wheel, that they could actually just use our policies and deploy them in their institution as appropriate. And that was really extremely helpful for them. And, I think it is a benefit to have many larger institutions that have a commitment to rural healthcare just create these consortiums that really improve everybody's ability to really function, both from a clinical perspective and financially.
It's a question on broadband. It was mentioned that in rural settings where patients do not have broadband access, reimbursement for medical services is now allowable for telephone visits. Are these telephone visits being reimbursed at the same rate as telemedicine visits? How important is this?
Well,
Kevin?
for us here in Knoxville, I'll just briefly say that it's been incredibly important because we have just where we're located, we have decent broadband as long as you're within one of the larger communities where services are available. But if you live out on the farmstead and not far outside of town, you're going to have broadband issues. And so being able to connect with our patients via telephone and to be reimbursed for that has been incredibly helpful, but it doesn't replace all the awesome things that modern technology can do via telemedicine. So it is not a replacement, but it's been very helpful.
There's a question on global payments that I'll relate. Could the panel speak to the impact of global payments for rural hospitals? Karen Geisinger is in Pennsylvania, which is testing a global payment model. And the BPC task force has recommended making such models available to other states. Is global payment an answer to improving the delivery of healthcare in rural areas?
Thanks, Senator, for that question. So we are participating in the Pennsylvania Rural Health Initiative, which offers a multi-payer global payment to rural hospitals that allows them a path to transform into a more sustainable model and really takes away many of the challenges that we talked about here today. Hospitals are not paid on how much they do, they're paid on outcomes and population health efforts in their communities to improve the population health outcomes of their residents. Vermont is another example of a global payment. Also, the state of Maryland has been running an all-payer model of global hospital payments. And really, the hospitals participating in these innovative tests and innovative payment delivery models have not really suffered as deeply as hospitals that are on fee-for-service. So I think for both urban and rural hospitals, global payments is definitely something when we talk about transformation and transformative payment that we should consider.
Although, Karen, one aspect of this is, so I'm also serve people in Vermont, and we have a hospital in Vermont and a large practice in southwestern Vermont. I think one of our challenges for our smaller facilities is that at least in Vermont, with more of trying to be a single payer, they have upside and downside risk.
Mm-hmm.
And downside risk for some of these small hospitals, just they feel like they can't assume it because if they have to pay downside risk, their payments for the next year are otherwise kind of committed, and they just continue to actually get into that vicious cycle of having operating deficits.
And I think that's upside downside risk. That's an issue. Whether I do agree that it's certainly the impact is much more difficult on smaller hospitals. But I think there's no model that we have perfected. I think the idea here is let's take a look at what the opportunities are, test them in different parts of the country, and try to evolve. These are evolutionary models. I think the only thing we can all agree on is that I haven't heard a lot of people raise their hand for fee-for-service.
Well, I want to thank each of our panelists. You've done an outstanding job of giving us a better insight and understanding of the tremendous challenges we face in rural settings across the country in providing healthcare. And we're very grateful to you for your commitment to health, for your leadership, and the extraordinary effort you make every day. Thank you, each of you, for the job that you do and how well you do it. Bill?
And thank you, Senator. Thank you. And thank you, Kevin and Joanne, Susan, Karen. A very thoughtful, informative, if not sobering discussion of the challenges that you're confronting out there. Second, on behalf of the Bipartisan Policy Center, I know Senator Daschle and I'm sure the panelists, for all of those out there that have been impacted by this devastating disease, our hearts and prayers go out to you. we really are concerned about this going forward. But if there is any silver lining in this crisis coming out of this, and I think we've heard a few here today, whether it be changing the payment structure, value-based movement, whether it be the apps and the technology and digital and provider to provider. If there's any hope here, I guess, is that somehow coming out of this crisis at the other end, healthcare delivery in rural America will improve coming out of it. That's our prayer. That's our hope. I think there's plenty good discussion here that would suggest there will be a different model after this crisis is over, and that will be to the betterment of the delivery of care to millions of Americans in rural America. Again, thank you to all of you, and thank you to the Helmsley Charitable Trust for this. We wish you all the best and stay safe. Thank you. Okay, I think we're back in, right?
While we're waiting, let me just say great job to each of the panelists. You really were extremely articulate and you were succinct and